Hi everyone. I want to talk about digoxin. Digoxin is a very tiny med, but it has a very strong force. Very, very tiny, but very strong. So don't judge by the appearance. Please don't. So let's go. We can trace the history of cardiac glycoside to Sir William Whitney in 1785, who first described the first growth plant, that is Digitalis purpurea, as being useful for heart failure. There are many cardiac glycosides, but in medical practice, we are going to limit any discussion to two cardiac glycosides. That will be digitoxin and digoxin. So briefly about digitoxin, it is rarely used in modern days, but it has the advantage of being eliminated by the liver, and that confers on it extra advantage to be used in mild to moderate renal failure, where digoxin may not be applicable. But I will limit my presentation today to digoxin, which is the one that we are using nowadays. And digoxin appears in various forms under different names like lanoxin, toloxin, digitec, apodigoxin, and so on and so forth. Examples of glycosides are digoxin, digitoxin, both from woolly and purple foxglove. They increase cardiac output, and as they do that, they also decrease heart rate, but they don't affect blood pressure. Like I said just a few seconds ago, that we're going to limit any interaction to digoxin and digitoxin because there are so many cardiac glycosides. Even then, out of those two, we are limiting our interaction to only digoxin because digitoxin is not that frequently used nowadays. So digoxin increase or can increase cardiac output, can decrease heart rate, but will not affect the blood pressure. A cardiac glycoside is useful in treating atrial fibrillation. I will refer you to my presentation on atrial fibrillation about a month ago. You can check my site. I'm going to see, I think, almost 5 of them in details. Also in atrial flutter, a heart failure, fetal arrhythmia. In this case, the mother is given the medication to treat the arrhythmia in the unborn child. Supraventricular tachycardia. We use digoxin, a member of cardiac glycoside, an example of cardiac glycoside, to treat all those situations. There's what we call digitalizing dose, and that is the loading or initial dose given to achieve a therapeutic effect, after which the maintenance dosages will follow. The mechanism of action of digoxin will be essentially that they increase calcium uptake into the cells. So when that takes place, more calcium is released on stimulation. The cardiac myocyte will have faster and stronger contraction, otherwise known as positive inotropic effects. They decrease heart rate. How? By increasing the refractory period of the atrioventricular node, and that is known as negative chronotropic effect. The mechanism of action has not ended yet. They inhibit sodium potassium ATPase pump and thereby increase intracellular sodium. They compete with potassium for binding site and they enhance vagal tone and decrease ventricular rate. Digoxin dosages are essentially going to be loading dose or neutralizing dose. You can give as high as 0.25 milligram to 0.5 milligram intravenously, but slowly over several minutes. Then you follow that up with daily maintenance of 0.125 milligram per hour, or could be less depending on what you're dealing with. In heart failure, however, the loading dose is not necessary. You can just start with your 0.125 milligram per hour daily. You may go lower depending on what you're dealing with. In supraventricular tachycardia, the loading dose could be as high as 0.5 milligram per hour. And 8 hours later, you give 0.125 milligram until you have adequate effect. In renal failure, you have to decrease the dosage appropriately. There are contraindications to digoxin, and there are hypersensitivity to digoxin. If there's history of hypersensitivity to digoxin in this patient, please don't use it. Also, check the EKG. If there's ventricular fibrillation, no digoxin. The adverse reactions here are dizziness, mental disturbance, headache, confusion, depression, fever, hallucinations, rashes, urticaria, pruritus, and angioedema. You can also have blood and yellow vision around objects, nausea, vomiting, diarrhea, abdominal pain, anorexia, ventricular tachycardia, ventricular fibrillation, can have heart block, and premature ventricular contractions, ST depression, asystole, and apathy. Digoxin toxicity is a serious issue and should be treated as such. Digoxin serum concentration normal range is 0.8 to 2.0 nanogram per ml or 1 to 2.6 millimoles per liter. So when you administer the digoxin intravenously, 4 hours later, take the blood sample and assay the serum concentration. But if you have given the medication per hour, 6 hours later, do the same. The symptoms of toxicity here will be first on the heart, and that will be cardiac arrhythmia. Sometimes may be asymptomatic for several hours, but when it is, CNS is affected with confusion and weakness. Yellow lines around objects should be prominent. There will be double vision, afraid to see lights, like photophobia, visual acuity will be decreased, and stuff will be blocking the vision, scotomas, and even blindness. As possibility of nausea and vomiting. As a matter of fact, most patients on digoxin are brought to the hospital because they could appear confused by their, by the judgment of their relatives, and that's will be the reason why digoxin serum concentration will be measured at the hospital, EKG, and everything will be done, and then the diagnosis of digoxin toxicity will be made. When EKG is done, it is expected that we are going to find ST segment depression, concave upwards, and bidirectional ventricular tachycardia. If this is not handled on time, from ventricular tachycardia, we can get ventricular fibrillation, asystole, and death. The treatment of toxicity will involve treating hyperkalemia by neutralizing the excess digoxin. Okay, and we'll start by checking the airway. Check the airway for foreign body, for secretion, for anything blocking the airway passage, the nostrils, the ear, the mouth, absorption as is appropriate, or remove foreign body as may be applicable. Check the breathing of the chest, deformity, moving with respiration, any tracheal deviation, auscultate, and all the likes. C for circulatory system, you check the vital signs, what is the BP saying, the heart rates, and any dehydration here, put an IV fluid up. You don't need to treat hyperkalemia directly here if it is not so scary, like greater than 7.0 milliequivalent per liter. Why? Once you start treating or once you start neutralizing the digoxin, the hyperkalemia will be corrected. Of course, the admission here is not just only in the hospital bed intensive care unit, because we need to monitor the cardiac effect. The EKG will be hooked up, and it's going to be continuous issue with pulse oximetry to know exactly what is happening to the heart down there. Like I said, the serum concentration will be now assayed immediately, and the normal range is 0.8 to 2 nanogram per ml. So you'll be able to predict and project how you're going to go when you know the value of the serum concentration. And in this case, it's going to be very high. The antidote must be provided. The antidote is antibody fab fragments. Some call it Digoxin, others call it digoxin immune fab. Either way you call it, anything you call it, just get an antidote, antibody fab fragment, 10 vials for adults most times, and depending on the hospital and the protocol, please follow that. We are going to repeat electrolytes, particularly potassium assay, but then we're not going to leave out all of the electrolytes like sodium, magnesium, and calcium, because on their own, they can each affect the heart and the entire system. Don't blame the entire trouble on digoxin. Find out if other meds or drugs are involved, and that would be any medication like calcium channel blockers taken here, and of course in toxicity right now, any beta blockers and clonidine. They could present in similar way, but the serum digoxin concentration will give clue that this is mainly digoxin toxicity. And of course, the level of potassium, because they compete for binding site. Potassium and digoxin compete for binding site. Don't miss that out anytime when you are giving your digoxin. That's why we assay for the level of potassium. In conclusion, Prevention is better and cheaper than cure. Watch out for other medications. And I'm going to talk more about other medications, their benefits, mechanism of action, and toxicity. Very soon, I'm going to make publication on aspirin. Be on the lookout. Thank you for listening to my presentation. Kindly subscribe to my channel so that you can get these publications as soon as they're published. Thanks.